So one of the things that we're most interested in, we still need to analyze this from INTRIGUE, is that we know that these tumors are driven by KIT. But the KIT is like the engine of a car, and these drugs are like the car keys. Let's turn off the engine. But the problem is that even though the keys work initially, over time the lock gets switched and the key doesn't work. And we know with any given drug, there's certain mutations it would work against and some certain mutations it wouldn't work against. Historically, the only way we could figure that out was to do biopsies, but even biopsies are problematic. If you have 20 different tumors and we biopsy one, we might understand that tumor, but do we really understand what would happen in the other 19 tumors? So what we're interested in the future would be most patients, 80% of patients with advanced GIST who would be in one of these studies have detectable mutations in their circulating tumor DNA. And so what we're trying to figure out are there subgroups of patients that we could use that information to tailor an individual therapy? Because right now we go first line, second line, third line, fourth line, based on historical factors and based on the order the drugs were approved. But it would be nice, in the future to say, well, maybe we don't do the second or third line drug because we can detect a signal that it's not going to work very well for you, but something else would work better. So I think that's the thing that we're very interested in. Out of the INTRIGUE study, we're hopeful that we'll see subgroups with certain patterns in their blood that gave extra benefit or not extra benefit that would actually allow you in the future to do a study where you might use the pattern to pick between drug A and drug B rather than we do drug B because that's what the FDA has approved second.